Ladies and gentlemen, it's a pleasure to participate in this ICS live. And this live is about quality in urodynamics. I am Enrico Finazziagro, urologist working in Rome, University of Rome Tor Vergata. And being a poor urologist, I need someone else to help me, and I have the privilege to have together with me today Andrew Gemmi. Andrew is a clinical engineer working in Bristol and probably is the right person to talk about quality in artifacts in urodynamics, being involved in research in this field, having been involved in research in this field in the last, I don't know, 10 or 20 years. Andrew, welcome to this live.
Yeah, thank you, Enrico. And for me also, it's a privilege to do it with you so that I'm not just in some technical bubble, but we have clinical input from you as a surgeon. So let's get started and look at our slides. I'm going to share the screen with you now, and hopefully you can now see our title slide. As this shows, and as Enrico said, we're talking about quality in urodynamic testing. And for this presentation, we're going to particularly look at things that you can do during the test to ensure you have quality. There are a number of other issues you might be able to look at in reporting and in annotating, but for this presentation, we're just going to make it practical and look at the things you can do during your test. To start with, just some disclosures to put up, and none of these affect the material that we've been preparing for today. So, does quality matter? Well, I'm going to hand to Enrico now and ask him whether this is an issue for the technical geeks, people like me who are a nerd and like the technical side, or whether it actually makes a difference for patients and clinicians. Does it, Enrico?
Andrew, I think that quality matters, of course. I mean, we have, you're showing in this slide, we have several papers showing that a bad quality can impact on the efficacy of the results that you can find during the urodynamic investigation. In particular, I would like to mention this paper that was done for the ICI Research Society in the 2018, and you were the first author. I was among the authors, and I think that we were able to show very clearly that a bad quality can affect the final findings of urodynamic tests. And I mean, if this is, let's say, the scientific part, but if you want to use the common sense, it is to me very, very clear that if you are using bad techniques or bad instruments, at the end we will have bad results. So it's something that it comes from the observation of what happens in the normal life. I don't think you want to drive a bad car and having problems on the road. I mean, so it comes from the literature, let's say, but it comes also from real life. So it's something very important.
Okay, good. So we're onto something that matters today, which is good. The format of the session is that we'll take us through some traces that have got some issue with quality on them, and I'll be able to explain the cause and discuss some possible solutions. And then for each feature that we discuss, I'll hand to Enrico, who can show how this is clinically relevant to what we do and why we are doing urodynamics. So first of all, let's look at one of the big issues of quality in urodynamics: resting pressures and zeroing. There are three main features that you look for in quality. One is the live signal, another is the cough test, and we'll come to both of those. And the third one is this, the resting pressure. Are you measuring a realistic pressure in the background of the patient when there's no cough, no movement, no bladder activity? And you can see up at the top right here, we've got the standard reference points that have been put in the ICS standards, basically from experience. We know that when you've got good quality measurements, that's the value that you should see in those different positions. So on this trace here, this is an example of what at the beginning of a test should like. To start with, we've got at point A, the domes or the transducers are all open to air, and you press 0, which means that you are zeroing to atmospheric pressure. That's the standard, as I'm sure you're aware. Then when you reach B, the pressures come up because you've opened the catheter to the patient. The tap has been moved or whatever your system is. And there you should see normal ranges as long as your transducers are level with the symphysis pubis bone of your patient. That should be within these values that we see up at the top right. Whether your patient is supine seated or standing, the pressure should be within this range. And then when you get to C, you can just watch the patient breathe. Those little perturbations on the abdominal, which is the red, and the vesicle, which is the blue, these little movements show that there's some activity inside the patient, which you'd expect if there's blood and air going around their system. So that's another indication that you've got a signal that is reflecting physiological reality. Then at D, the cough test comes in, and you can see that they're both the same height. A cough should affect the abdominal and the intravesical pressure. In fact, every organ within the pelvic cavity, exactly the same. So you'd expect that those pressures would be the same, and then on PDET, this subtracted signal underneath the green should stay pretty well level. And then at E, we can put our marker down because we've seen all the quality signals here, and we can now record the baseline pressures for this particular patient. And all of that should happen before we start filling. But sometimes people might do that without calibration. And of course, it doesn't make sense. If you haven't calibrated next to a known value, then your system is just reading random figures. So make sure first you've got calibration done and checked in the recent past. So does this matter? Why should we bother? Have a look at this one here. Can you make out the abdominal signal is quite high? It's about 50 to start with, right up at the top. But the vesical pressure is near 0. Now, for whatever reason, the user has chosen to ignore that. And this 0 signal down here has completely flattened all it out. It said, I know it says 50 on P-out, but let's forget about it. Let's force it down to 0 and see what happens. Well, that is a problem for quality. Why? Well, firstly, atmospheric pressure is your international standard, the 0. If you put 0 to this other pressure in the abdomen, you're not at the standard. But also, you won't be seeing normal resting pressures. Here, resting pressure appears to be 0 inside the patient. But that's not a physiological pressure. You and I do not have 0 inside. So another reason is that you've got to have normal resting pressures related to 0 to atmosphere because you need true values to make the diagnosis. And you could even do that 0 when there's a pressure rise. Pressure in the bladder rises because of a detrusor overactivity. You say, call that 0, and you ask, call what 0? You say, well, I don't know, just call that 0. It's non-standard, it's unknown. And the last reason where I'd suggest zeroing to atmosphere is necessary is that you don't get any negative pressures later on when any of them reduce for some reason from that start. So Enrico, can I put the question to you? Does this make sense clinically? Is it important for your patient?
Yes, I think absolutely it is important. I mean, there are many aspects that you have already shown, but just to remain to the, let's say, resting pressures, it is absolutely important to understand. In my clinical practice, for instance, it's, as you already mentioned, it's important to understand that you are recording the right pressures. I mean, if you have different pressures in the bladder area and in the rectum, there may be some problems in your system or in how you have put the catheter and the rectal balloon, or there may be problems in the connecting tubes. So it's very, very important that you start with the right pressures. And of course, the zeroing aspect is also important, as you mentioned already. If you don't have let's say a standard zeroing, then all your the following findings you will have will be wrong, or will be not completely standard, not comparable to other studies. So it is important from also from a clinical point of view. Another point is that when you will zero to the real initial pressures, if you will have a decrease in pressures in one of the two lines, it will be much more easy to recognize it than if you zero both lines at the beginning. And so you start from 0 in the bladder, 0 in the abdominal, and then you go to a negative value in one of the two lines. It will be much more difficult to understand. And when you go to a negative value, we will have an addiction. We will put for instance, the p-abd value over the p-ves value. We will have the sum of the two, and this will change the final results of your investigation. So it's very important. I think this is the real basic knowledge of urodynamics one should have before starting a test. I mean, if you don't have this knowledge, please don't do urodynamics. Please ask someone else to do urodynamics for you, because otherwise all your findings will be wrong.
Right. Okay, so we need to be measuring real pressure, and we need to make sure that atmospheric is our reference point. That's fine, it does make a difference. So if I move us on to the next item of quality, which is the cough test, and many of us are familiar with this, I'm sure. Here's a good example where the patient coughs on this left-hand side, and the abdominal pressure goes up beautifully, but there's absolutely flat on the vesicle line. And this huge pressure rise here is the flush through, where we're pushing water through the dome, and look what happens afterwards. It's restored. Vesicle and the abdominal line go up together beautifully and nicely subtracted out with very little movement on the detrusor. So probably what the issue was here was an air bubble in your water-filled system, and it just needed pushing out, so you got a water column only transmitting your pressure. Sometimes, though, you do find that at the beginning, like here on the left of this second picture, your cough after the flush doesn't quite respond well, and you still get this big negative spike. What we did in this case was look at the volume up at the top. We started the pump, and it filled a little bit of fluid into the bladder, which meant that the catheter was now surrounded by water. And then this cough test up here was fine with no more flushing. Do you think there's an explanation for this, Enrico? Why does it happen sometimes that you need to fill the bladder a little bit?
Yes, I do. I think it happens. It happens because we are making measurement in a human body, not in a machine. So sometimes you put a catheter in the bladder. Maybe sometimes the catheter may be a little bit curved. Sometimes we push a little bit too far the catheter inside to be sure that is really inside the bladder, and maybe there is a curving of the catheter inside. And when the bladder starts to fill, this curve this curvature will resolve a little bit, and the recording will be much better. Or maybe the catheter is too attached to the bladder wall, so it's impossible for the catheter to record perfectly. So sometimes a little feeling helps, as you mentioned. It's quite normal. It is important to start with the cuff test and to feel the system, as you have shown already. Again, this is something that is very basic knowledge to have before starting a urodynamic investigation.
Okay, good, thank you. The next thing that can happen during a test is that you get a pressure descending. We've actually mentioned this in passing already. On this trace, you can see actually that it is starting all at 0. So we've already failed one of the quality tests, because the pressure inside our patient at the symphysis pubis is never 0. We're related to atmospheric pressure. So they must have set the 0 inside the bladder, whatever the starting pressure was. And as we've explained, our standard is to make 0 the outside pressure and then register the pressures inside the body with respect to that. But the point here is that it can be also seen that the abdominal line is descending slightly. Even though these little coughs are being picked up, the background resting pressure is going down. But our patient is not losing weight. There's no change inside them that is suddenly decreasing the pressure. So there's a problem. And for quality control, you've got to recognize that. And in this case, if it's a water-filled system, the abdominal pressure line should be flushed, just to restore that water inside the balloon that connects with the rectal cavity. Sometimes you can just reposition it, actually. So when we have this descending pressure, you've got to make sure, if you see it, that you rectify it, because the pressures are going down. That's during the filling phase. Can it happen during voiding as well, Enrico?
Yes, Andrew. It may happen or it may happen also during the voiding phase. But coming back to the filling phase, I just would like to underline that if you look at this trace, you are not an experienced urodynamicist. You may see an increase of P-det that is not a real increase of P-det. It's just because of the decrease of the P-abd. So you must be able to recognize this artifact. Otherwise, you will see a detrusor contraction that is not there, or a poor compliance that is not there. Just because of an artifact. So this is a very beautiful example on how an artifact can impact very deeply in your diagnosis if we are not able to recognize the artifact. Coming back to your question, yes, it may happen during the filling phase. In my experience, it may happen because the rectal balloon may be positioned a little bit too near to the anus. I mean, too caudally, let's say. And so when the patient relaxes to start the voiding, there is a slight decrease of the rectal pressure recorded by the balloon. So there is a decrease on the P-det that we put on the P-det. So we will have a P-VES plus a negative P-abd that will increase the value of the P-det. And you should be aware also of that and check also during and after the voiding phase that all your system was recording adequately.
Yeah, thank you. So that's a good point, that whenever you see a descending line, you need to correct for it, whether it's filling or voiding. Another point during voiding can happen when the patient is straining. And you can see in this case that the pressure is going up on the red rectal line and the blue vesical line together. So the patient is pushing out. These little bits of urine on the bottom is your flow line, and they only come out when your patient is straining. But look what happens on the detrusor line. You've got these bumps in pressure that come up with every strain. And it's because the P-abd is not going up to the same height as the P-VES. Just like a cough, and there's a little cough here in the middle, it should go up to the same, but for some reason it doesn't. And we have postulated in the past that this might be due to the fact that a full bladder pushes back differently on the rectal line or something. We don't actually know, but it is known that you do get sometimes these bumps on the detrusor line, rises in pressure because of a poor subtraction during straining. And the point is here that if you are interested in your patient's detrusor function, you're testing the bladder's activity, then you need to ask your patient not to strain if at all possible. See what happens without the strain. And then if they need to strain to void at all, then of course you let them. But it's often very helpful to try it without the strain, because there are times when this detrusor pressure is misleading because of this activity that is not reflected on the abdominal line. Does that make sense, Enrico?
Yes, absolutely, Andrew. And sometimes, again, if you are not an experienced urodynamicist, or you may just take the results from your machine, and your machine can tell you that the P. Sorry, I don't know if I touched something. But the machine can tell you that the maximum detrusor pressure was I don't know, 50 centimeters of water, but this was not true. This was just because there was this difference in recording between the PVES and the PABD. So it's again, it's an artifact. It's not a real pressure. If you want to try to recognize the real detrusor activity, the detrusor pressure, you have to ask the patient not to strain, or to try to examine a part of the trace where there is no abdominal straining, so that you can understand better what is the real detrusor function.
Yeah, so here's an example of one where you've got to try and place your points of maximum flow in between those ridges that are due to the strain. So try and look at your signal to see what reflects the background detrusor activity rather than this extra pressure due to strain. Just something to be cautious of, and in your test, instruct your patient not to void if that's not to strain, sorry, if that's possible. So here's an example of that third sign of good quality. We've got the resting pressures, we've had the cough, and now the live signal is our third one. And look here, you've got between these two cough signals, the first one is good, the second one is still pretty good. In between, you've got all of this activity where your patient is, you hope, still breathing, and it's mostly subtracted out on the detrusor line. A bit of activity there, but it's not too bad. So that indicates you're picking up a live signal, which is great. But there are times when that live signal is lost. Sometimes during filling, one line goes completely flat. Here's an example during voiding, where the vesicle line has gone completely flat. And we find this does sometimes happen with a large bladder as it gets empty, that the vesicle line stops responding. You see at the beginning of the void, as per standard, the patient is asked to cough with these two signals here. Then they void, detrusor pressure comes up, and maximum flow is reached at a value of 10, and this pressure here. And then it's after that point that we start to lose that live signal. And when they cough during that end of voiding, here's the cough on the abdominal line, but there's nothing on the vesicle, it's lost. So the detrusor's got this big negative spike, which is an indication of a problem. Later on, it actually comes back. Your cough is good. The bladder's pretty well empty by then. But in the middle, we can't trust that signal. It's got a loss of these quality indicators. However, in this case, if the quality that if the point you're interested in is the maximum flow, and you want to see if this patient is obstructed by looking at detrusor pressure and maximum flow, the question is the quality still okay at that point? And the answer is yes. Live signal, good cough, and normal values. So we can actually use that point for our diagnostics, even though later on the quality is poor. So, Enrico, is there any explanation for that? Can you think why clinically this might happen in a patient?
Andrew, I'm not sure. I don't have probably I don't have a proper answer for this question. But what I would like to say is that one should be able to recognize this. I mean, you should be able to understand that something is wrong in this trace, because there is not completely, there is a lost, let's say, correspondence between the PABD and the PVES in the second part of the voiding phase. And I think that you should be able to understand it. It is true that you can still rely on the first part, so you can calculate the PDET and PDET Qmax and the Qmax, of course. But I would suggest in a case like this to repeat the voiding phase if possible. I mean, to do another filling, another voiding completely, because sometimes urodynamics, a message that I would like to give to everybody is that sometimes urodynamics go smoothly, sometimes they can go, I mean, very with many difficulties. So sometimes you have to repeat the filling phase or the voiding phase because of technical aspect. It's better to repeat the investigation than to have a bad result at the end.
Of course, yeah, if there is any doubt at all, then you need, for the patient's sake, to repeat it. And that reflects also the fact that we need to ask the patient, was that representative of their usual void? Is this reflecting their normal life? Because if it isn't, then you're not really answering the urodynamic question necessarily. That's a good point. So that finishes just a quick view of some of the quality indicators. What we'd like to do in closing, before we have the chance for questions, which you can deliver on the ICS website, before those questions, just to give you a little bit of a flavor of a quality assurance project that we've started, and it's got 4 aspects to it. The first one is to develop some sort of quality assurance system so that a clinical department can send in a trace, have it reviewed by someone else, and then sent back with comments. And we hope that that will give your department and yourself as an individual an ICS reference indicator of quality, saying, yes, our department's traces are good, they've been independently reviewed. It's good for your audits. To assist that, we're trying to develop some metric so that you can measure and therefore manage the quality of your traces. And that eventually might be able to be put into machine software to indicate if there's problems. We're also updating the ICS training programs and trying to get them standardized and accessible so that each group can learn, whether they are just being introduced to a urodynamic machine or if they're experts or clinical scientists or whatever, there's still something there for them through the ICS to have some online training. And then rather longer term, we're hoping that in the end of the day, we'll have some system to accredit departments, something that's realistic, not overly burdensome, but it would give patients and providers the assurance that this department is known to do quality urodynamics. They have the right training, and hopefully we can get rid of some of those questions over urodynamics that may have arisen through questionable practice. So Enrico, is that something I know that you're interested in yourself? You've seen that summarized before.
Yeah, yes, I do. I think that this is a very good project, and I'm very happy that the ICS Urodynamics Committee that I have the honor to chair is collaborating and working with you on this project. Some of the part of this project will be easier, I guess. The part of, let's say, of the metrics to assess the quality of urodynamic trace is something that we have already started, and I mean, very, very soon we will start to see, I hope to see many traces coming from ICS members to share our experience on how to evaluate those traces. Other parts may be more difficult to get, because the accreditation of departments will depend on different national systems, different regulations that will be local at a local level in different countries. So it will be more difficult to obtain this aim. But I think that we have to start from a point, and I think that this project is a good start to help also other, all the different countries to try to have a standard for the accreditation of practitioners and departments for assuring good quality in urodynamic evaluation. I think this is an aim that we as ICS should have, because as we discussed deeply in this 30 minutes, quality in urodynamics is essential to have at the end good urodynamic evaluation, good urodynamic results, and good diagnosis at the end to help really our patients.
Yeah, great.
This is the point, I guess.
Thank you. Yeah, and it's good to acknowledge that Labrie are helping us with the sponsorship of some of this work, and also the ICS office team are doing a fantastic job on the background for the software and management of this, and we're grateful for that.
Yeah.
So we
Andrew,
reached the point where there's any questions, I think.
Yes,
Enrico, over to you.
Andrew, I must tell you that I'm very honored because among our audience, I see from the questions there is Peter Rosier, there is Chris Fry, so I mean important members of the ICS. So
yeah,
I'm
no pressure.
honored
I'm feeling
for that. Yeah. The pressure is high now. I mean, the one question comes from Chris Fry. There is also the answer already from Peter, but I mean, I want to pose you this question. The question is, do you think that we could reference the pressure not to an atmospheric level, but to something that is inside the patient, so that you won't have differences when the patients change of position, sitting or standing? He makes the example of the atrial pressure, the right atrial pressure, that is a standard, let's say, pressure for the cardiovascular venous system. Do you think that we may use an intracorporeal pressure as a point of reference instead of the atmospheric, and do you think this may help in a way?
I think it would remove the global standard, in the sense that it would be more difficult to refer the absolute values that you're measuring across patients if you had a within patient reference. But the other picture that I often use in terms of trying to understand why it's reasonable to use atmosphere is that that's what our bodies are doing. The skin is holding in the organs with respect to atmospheric pressure, not a vacuum outside. And so our interest is in what the performance is of those organs related to the reference point of the body, if you like, which is the outside pressure. So I see Chris's point in terms of an individual organ, but I think that in terms of a whole patient and a patient population that we want to compare, then you do have a good reason for that atmospheric zero.
Yeah, I agree with you. And I think at the end, it's also useful to use atmospheric and to have different pressures in different positions. It may help us in the end to reach, I mean, better findings, let's say, in our patients. And Peter agrees with us. I mean, Peter says that it is not essential to have this let's say intracorporeal, intra-body point of reference. Peter is asking also if we can say something about the rectal balloon and what should we use as a rectal balloon, if I understand correctly his question. So if
yes, I probably mentioned as we went along without explaining it, that the abdominal pressure is most often measured, and it is the ICS recommendation, with a small balloon placed in the rectal cavity up above the anal verge, and we found that 10 centimeters in is a good aim point where you get beyond all those pelvic floor interference. And the rectal balloon itself is filled up with water, so you've got the water column taking the pressure from the patient down to the transducer outside, but it has a small slit in it so that any excess water does not build up the pressure elastically. It actually flows out into the patient's rectal cavity. And as long as you don't put too much through, that isn't a problem in our experience. So it's a small balloon that inflates inside with a bit of water and touches the rectal wall, so it picks up abdominal pressure that way. Thank you, Peter, for the prompt to explain better.
Yeah, I agree. And I would like to underline that it's important not to fill too much the rectal balloon, as you mentioned already, Andrew, because otherwise you may have an unreal pressure inside the abdomen that is due to the elastic tension of the balloon itself. Andrew, I think that you were very clear in your explanation. I think at this moment we don't have more questions to answer. We have finished our time, actually. So I think that of course, people can still ask questions after the live, and I think that we will be able to reply in
of
the
course, yeah, very happy.
next days to other questions. So Andrew, I would like that you close this this session, and I would like to thank everybody for their attention. Andrew.
Yeah, thank you. Just to say farewell and to underline Enrico's invite for you to write in any questions, use the ICS live website as that forum, and we'll do our best to regularly update that with answers, and look forward to being in touch that way. Thank you for all attending.
Goodbye.
Goodbye.